everyone. Today we're coming to you as part of the MUST program, which is Major Understanding by Selected Topics. Today's topic is, what have we learned from COVID-19? We've learned two very important principles from COVID-19, individual risk assessment and the tangled hemostatic web. Now, as far as risk assessment goes, we know there's a multi-platform NIH a series of studies that are beautifully done studies that show that therapeutic anticoagulation is better than prophylactic anticoagulation for people who aren't in ICU. And for ICU patients, it didn't help to use therapeutic anticoagulation. The ACTION trial, which is another very well done trial, showed just the opposite, that as prophylactic anticoagulation was better than therapeutic anticoagulation. What's going on here? Why the difference? Well, one possible explanation is there's no detailed risk assessment. And we have learned from the Michelle trial, now just published. The answer to that is very likely because the Michelle trial showed, using the improved score and rivaroxaban, that the 30-day incidence of VTE after discharge could be reduced by a relative risk of 65% using scoring in COVID-19 patients. Now, the other thing that we learned from COVID-19, a long time ago in the 1800s, experiments were done showing that the activation of factor 12, the clotting factor, also activated the not only the clotting system, but the immunologic system and the inflammatory pathways, so that you got, when factor 12 was activated, it resulted in thrombosis, fibrinolysis with possible bleeding, kinin release with angioedema, increased vascular permeability, hypotension, vasodilatation, histamine release, and inflammatory cytokine release. And all of these things, Oscar Ratnoff told us, were pieces of a puzzle. And the body doesn't work on those pieces. The body defends itself as a whole. So until all of those pieces are put together, we don't really see the full nature of the puzzle. Now, we know one thing for sure, anticoagulation alone isn't the answer. And we know that the clotters and the inflammatory doctors and the immunologists have to continue to get together in order to attack this disease. Thank you very much.
Welcome everybody to what will be a sort of precious virtual coffee break with honestly my hero, Professor Caprini. Indeed, we started great with him with this major understanding by selected topic. It's a must, knowing Professor Caprini and his knowledge in the venous and lymphatic and also arterial field, of course. And it's a must to have good education on travel mates, starting from Mexico, with Dr. Alejandro González Ochoa and Dr. Erasto Aldrete, who I deeply thank for being with us today. So this will be an informal moment, as you can see also from my dress code, that is, though, like precious, because I have Professor Caprini here with me with a precious t-shirt, because indeed, this is like when you are stepping out from the meeting room, and indeed we have already enjoyed the video appeal of Professor Caprini focused on what we must know about the difficulty of the pandemic of COVID, but also the opportunity in understanding more about thrombosis. So thank you so much, Joe. Thank you so much, Erasto. Thank you so much, Alejandro. We will now have Alejandro, we just start in alphabetical order, I would say, making a comment or a questions after having enjoyed this, of course, as always, spectacular contribution of Prof. Caprini. Alejandro.
Yeah, well, like Dr. Caprini said, the importance of anticoagulation in the COVID patients is very, it's already proven. Patients need to be at least prophylactic with dosing, be protected. And also the importance of trying to select which patients are going to be needed to give that prophylactic or anticoagulant dose. Now, my issue is that not all the anticoagulant therapy is the same. We have heparin-based anticoagulation, prophylactic or therapeutic dose, whichever you want, that has some important pleiotropic properties outside of the anticoagulant effect, compared to DOACs or warfarin, that it doesn't have that important anti-inflammatory effect. And maybe this has to do something with the prognosis in the use of the patients, and even more so if it is started early on, because once the patient is in the ICU, the disease is flowed up. It is all over the place, the inflammation and all that. But maybe if trying to protect these patients in the early stage, that is why some of the recent trials have shown some benefits. So I don't know, Professor Caprini, what do you think? Is there a benefit regarding using drugs, using heparin, using warfarin, is there some difference regarding these treatments?
Those are very, very excellent questions and excellent points that we've all been struggling with since this COVID-19 began. Now, I would like to go back. I am a real fan of history. And I think that a lot of times we have forgotten history. So that what I would like to talk about is some things in history. And the first thing in history is the tangled hemostatic web. Oscar Ratnoff, who was a famous hematologist, who actually, when he was born, was a premature, and his father was a pediatrician. They told his father to let him die, he's too small, and his father nursed him with all his skills and hot water bottles. So then Oscar comes up, and he and Davies devised the coagulation cascade, factors 12, 11, 8, 9, 5, 10, calcium, all that. And I think he was a little disappointed he didn't win the Nobel Prize for that. He probably should. But he did something else. He found this patient, John Hageman. And John Hageman had no contact factor, factor 12. So he named it Hageman factor. And he went back in the literature and showed that in the 1800s, there were 4 experiments that clearly proved that when contact activation of factor 12 occurs, it triggers platelets, coagulation cascade, fibrinolysis, but the complement C1, C5, C6, the inflammatory pathways, and the antigenic pathways with bradykinin, histamine release, serotonins, vasodilatation, shock, hypotension, and so forth. Unbelievable collection of reactions. And remember now, if you get a bee sting and you have an antigen antibody reaction to the bee venom, that's one thing. But what Oscar showed from the 1800s was that you can have that same reaction without an antigen antibody reaction mediated through the contact activation. So let's carry this a step further. We know that the alveolar endothelial interface in the lungs is the virus has a predilection to attack that interface and those endothelial cells first. And of course, the virus are like arrows, and they pierce the endothelium, facilitated by an ACE2 receptor. And once that happens, this whole constellation, the explosion, you might say, the tangled web, it explodes. And so cutting to the chase here, there's 2 things that you could really do to blunt this. And you alluded to the first one, because I have a slide which has about 18 additional features of heparin, effects of unfractionated heparin, because it's a 50 sugar chain: anti-inflammatory, anti-neoplastic, antigenic, anti-inflammatory. Beautiful. And you would take that and put it in with the web, and it would block the web. It's not that simple. First of all, this web is a really big explosion. It's the difference between a dynamite stick and a firecracker. And the effects of, so I think this is a good way to think about it. The effects of heparin, and we thought in the beginning, we all went to the heparin, but then we quickly backed off, because in order to give heparin, I loved giving IV heparin. That was a beautiful thing for all those years. Really got us through a lot of tight situations. But that meant a lot of interactions with these COVID patients, and the nursing personnel were dropping over like flies. And so that wasn't feasible. So we went to a low molecular weight heparin, which is 15 sugars, still has some of these properties. But again, the difference, here's the other difference, is people forget. Unfractionated heparin has a 50% bioavailability for the clotting proteins. the glucosaminoglycans bind to proteins, but the unfractionated heparin only binds to only 50% clotting proteins and then 50% other albumins and globulins. Bingo, you go to low molecular weight heparin, 90% bioavailability. And that's been the secret with low molecular weight heparin. That's the first secret. The second thing is that unfractionated heparin carries a 2.5% risk of HIT. And we know that we're getting HIT-like reactions certain times to certain of the COVID variants, especially sometimes even rarely to the vaccines. And some of the severe manifestations of COVID can be looking like DIC, so that you confuse that with the possibility of heparin-induced thrombocytopenia. That's another big disadvantage. 0.2% with low molecular weight heparin. 90% bioavailability, 0.2% with low molecular weight heparin. We don't know enough about DOACs. I mean, why would you do that? In other words, it's like flying without a parachute and you're not sure that the plane's going to fly. I mean, yeah, they're wonderful drugs. This is not the time or the place. Low molecular weight heparin is the drug because of what I've said. And in addition to that, I think it should be administered in large doses to most patients. But now here's the other thing about history that we forgot. It took CHEST till 2012. Up to 2008, Bill Gertz, who was running CHEST, said we think that risk assessment, we don't think individual risk assessment it's too complicated. We don't know what to make of it. He was speaking specifically of the Caprini score. And he said that we assign prophylaxis according to types of surgery. And then all of a sudden in 2012, finally, the authors conclude Caprini score, Rogers score, and that was in 2012. And now all the way up to now, we've got Padua, we've got Improve, we've got Geneva risk score. There's many roads to Rome. And all of the scores work, and they're good in different circumstances. Not one score will work. All of a sudden, we get to COVID, and nobody's scoring. Now, one of the reasons nobody's scoring is that everybody's coming in deathly ill, and nobody's taking histories and physicals that are worth a damn. And it's just like this. It's like a stampede. So that was one thing. But then finally, and Alex, I admire Alex. I've known Alex since the very beginning, and Alex had the passion, the wherewithal, able to convince people, and he has established that improved score, both for inpatients, of course. Well, he did that before. He had a 50, 55 or 60% risk reduction in medical patients who are ill before COVID. Well, why wouldn't you start doing that when you get to COVID? COVID's another medical illness. It adds inflammation. So that was one thing. And then the next thing is that finally, and we can talk about this, we have these beautiful trials, the NIH multi-platform trial with 2 big articles in the New England Journal, genius investigators. I couldn't hold a candle to any of those people. And then we go to the ACTION trial of South America. And so first of all, the big multi-platform said that prophylactic anticoagulation was better than therapeutic anticoagulation, but not for ICU patients, just in the general ward. What are they talking about? ICU are our sickest patients. They need it the most. Wrong. What that was, and I think that Alex, so I got this idea because I've watched what Alex has done with the HEP COVID trial, which is just out. And so now getting back to the ACTION trial, the ACTION trial didn't show a benefit. And so then I said, is the reason risk assessment? Well, then Alex comes along, and with the improved score and so forth, Alex clearly shows that early anticoagulation is more effective. And I think that it's very clear why it's more effective, because you blunt coagulation, platelets, fibrinolysis, complement inflammatory reactions, and the kinins. All the sooner you get to them, the better. And you made the comment, once that patient gets to the ICU, the cat's out of the bag. They're too severely ill. And as a result of that, why it really doesn't make you're really not going to do very much. A lot of times we will do that, in desperate circumstances, but there's another really tricky problem with this COVID in the lungs. And first of all, we're seeing a lot of primary pulmonary thrombosis for the first time, as we are seeing thrombosis at every place where there's an endothelium. But the other thing is we're seeing is pulmonary hemorrhages. And if you get a patient in ICU that's got those ground glass lungs, and you start jacking that heparin up, you run the danger of increasing what would already there be pulmonary hemorrhages. So I think I'll quit.
Yeah, that is great, Joe, as always. But we will have virtually to go back to the meeting room soon because we have just a 15 minutes coffee break. No, it's like, it's just thank you. I am sure Ale is happy with the answer. Is it fine for you, Alejandro? You're mute. You're on mute.
And definitely, it's very. With Professor Caprini,
we know, and of course, this recording will go in a platform where everybody can make comments and questions. So this will go on. We are just, of course, triggering discussion.
No,
and
but
now,
I think Erasto can go there.
Erasto, it's your time to enjoy the last 5 minutes of this virtual coffee break with Professor Caprini.
Okay, it was great. Your talk, Dr. Caprini. I would like to go back to the endothelial cells. We in Mexico have a lot of patients with that are obese and have diabetes. So we have, when they get COVID-19, they already have some endothelial dysfunction. And we can see that younger patients die at earlier stages. And what would you think on these previous endothelial dysfunction on these patients? And what can we do to avoid or to try to get better prognosis for these patients?
Well, I think that you've put your finger on an extremely important topic that I don't think a lot of attention has been paid to, and that is endothelial dysfunction in diabetes and other morbid conditions, the morbid obesity syndrome, that type of thing. And so I think that the endothelial cell is really a critical target. And if it's already damaged, as you allude to, if it's already damaged, then I think you have to hit those patients early and hard with full anticoagulation with low molecular weight heparin. And again, how you do that is with a risk assessment, because all those factors are there. And you don't have to use anybody's particular risk assessment, just following the book and say, oh, well, Alex says this or Caprini says that. No. Clinical judgment. And I think that's a really good thing that you've sort of put in my mind today, is making sure that if I see patients with risk factors that have endothelial dysfunction to begin with, that's an additional reason to hit them hard and early with full anticoagulation.
And guys, I would like to take my chance as well to enjoy this coffee break, because every day when I'm discharging patients after a venous procedure in this COVID time, I'm actually giving 2 extra points, right or wrong. So I will ask Professor Caprini himself and also Erasto and Ale, because I suppose they could become asymptomatic positive and then have an extra risk of thrombosis after venous procedures. And we know that in reality, the literature is really heterogeneous about the risk associated with the venous procedures. And it would be nice, and we will do this with Professor Caprini, reaching out to the colleagues to understand in a registry if there are procedures that are more prone to develop thrombosis or not. So how much do you think I'm wrong in giving 2 extra points, Joe, to my patients, just because I suppose they might be positive, asymptomatic in the following days after the procedure? And same to Erasto and Ale.
I think it's an excellent idea, and there's very little downside to that. And the reason why it's so important is that's going to take certain patients who have a score of 3 or 4, maybe 5, and it's going to elevate them into the higher risk group where they may benefit from longer than 7 days of anticoagulation. So I think that's very, very important. And we have to remember too, and of course you probably need to do this ahead of time. If those patients test negative, and then they're okay, and probably their D-dimers aren't up. But if the D-dimer goes up, that's another 3 points. So and again, you've just taught me something, which I think is brilliant. And that is, you have a patient, the patient's been quarantined for 2 weeks because they want this surgery. They come in and they've seen nobody or done anything. But then after the surgery, a few of the relatives start to come over, and maybe they want to go out a little bit because they're feeling good because you did a good procedure. Now you're exposing them, and they're very, very vulnerable. And we know the data that if you had a COVID patient and you didn't know they were positive and you operated on them, they had a 25 to 28% death rate and a 50% chance of a VTE. So I think you're right on. And I think that's a very important consideration. I'll have to remember that.
So in this virtual coffee break, I'd like to ask to the friends Erasto and Ale the most difficult question. Would you disagree with Professor Caprini?
Not at all, not me.
Well, I would challenge that because I'm not sure in all of the patients. I know we're talking about risk assessment, but in some patients, I do not think that applies because I know that you're going to be protecting a lot of patients, but you're going to be elevating or extra elevating some of the patients and doing some extra anticoagulation in some patients that you won't mostly need it. In particular, trying to use the Caprini score in venous treatment or in vascular disease treatment or surgery, for example. Because very quickly, I can give you some of my regular patients. I can give them like a 5 or a 6 Caprini score and not actually have a thrombotic risk. And if I give them a suspect high risk of probably having COVID and given those extra 2 points, I will be anticoagulating 70% of my practice for venous.
Good that you brought this up. We've got to straighten this out right now.
Yeah,
5 and above is not high risk. The meta-analysis of Panucci shows that people who have a score of less than 7, not only doesn't heparin work, but it not only is it doesn't prevent thrombosis, but it's not effective because the score has to be over 8. Now, the ASH never bothered to change it to what has happened in all that. We have 233 studies. ASH 2019 put 1 Caprini paper on there from 2005. Somehow they've ignored all of this. So people all over the world think a score of 5 is high. I wouldn't give any patient with a score of 5, 6, or 7 who's having varicose vein surgery. It has to be 9 or above is the target.
Yes,
And that's so it's very specific, very specific.
Specified that for vein treatment, a Caprini score of 4 or 5, it is not a high risk. You need above 8 to be more a high risk. So
that's right.
That's why you need to be a bit more specific, trying to apply that specifically in vein treatment. So
well, I have presented that in my lectures, but unfortunately there are people, God bless them, that if it's not in the guideline, it doesn't count. So we're fighting an uphill battle right at the moment.
Yeah, and I truly think this would be worthy another must session because we must be aware of the risk we are exposing to our patients. I think varicose veins have been under-considered in general, yes. Also for the fact that you just give 1 point independently by the kind of procedures with all the different techniques that are now available out there. I think we should really work on that, and I'm beyond thankful to Professor Caprini to allow us to work on a registry that soon we will propose to you so that we can have more data on that. I think we have to go back to the meeting room virtually because the coffee break is over, so I will just take one last chance of having Professor Caprini with us. Just a final take-home message, Joe, if you should give it about what we have learned, like the most important thing that we have learned.
Well, I think the most important thing we have learned is not to ignore history, to risk assess your patients, and remember to understand the tangled hemostatic web because it's a critical factor in this whole disease.
So this is what we must, as per the initiative, know, according to Professor Caprini, and we deeply thank from Mexico, Professor Ochoa and Professor Lee for having been with us. Thank you so much, and see you in person soon, hopefully.
The coffee was great.
Thank you all. Ciao.